Good day, everyone. My name is Rino J. Fernandez, your focal point for suicide prevention and management for male forensic ward. So welcome everyone to part 4 and the last part of the pre-recorded webinar series on suicide management for male forensic ward staff. Today's topic is about suicide assessment, 5-step evaluation, and triage, or safety. By the end of this presentation, I hope that all of you will be able to first define risk assessment and differentiate risk factor from protective factors. Second, list the 5 steps of safety. Third, apply the concept of safety in a given case vignette. And lastly, to utilize the safety tool into the clinical practice. So these are some facts and figures about suicide. Suicide is the second leading cause of death among 15 to 29-year-old. Over 800,000 people die by suicide every year, which means one death for every 40 seconds. 75% of suicides occur in low and middle income countries. There are more deaths from suicide than from war and homicide together, which accounts for 57%. Pesticides, hanging, and firearms are the 3 most common methods used globally of people committing suicide. Suicides are preventable, and there are effective preventive measures that we can implement to prevent suicide. First is restricting access to means, responsible media reporting, introducing alcohol policies, early identification and treatment, training of health workers, and follow-up care and community support. Key is a comprehensive multi-sectoral approach, which means that the media, government, and civil society should work hand in hand in order to create goals that will help prevent suicide. Most countries currently do not have a national suicide prevention strategy. According to the World Health Organization, 10% reduction of suicide rates is the target in the Mental Health Action Plan from 2013 to 2020. So now let's proceed with risk assessment. So what is risk assessment? This is actually a process wherein we identify the factors which can predispose a person in committing suicide, as well as determining the factors that can help the patient prevent himself from leading into committing suicide. So the definition, risk assessment is an estimation of risk potential based on our understanding of the presence and relevance of certain conditions that we assume to be risk factors and the absence of certain other conditions that we assume to be protective factors. It means working out how likely it is that a hazard will harm someone and how serious the harm could be. So risk assessment is a process wherein we determine the lethality of the possibility that the client might commit suicide. So now let's define risk factor versus protective factors. First is risk factor. Risk factor is any attribute, characteristic, or exposure of an individual that increases the likelihood of developing a disease or injury. So what are the examples of risk factors? This is our sad persons: the sex, the age, depression, previous suicide attempts, excessive substance use, rational thinking loss, sickness, organized plan, no social support, stated future intent. So these are an example of risk factor. Protective factors, however, are conditions or attributes, skills, strengths, resources, supports, or coping strategies in individuals, families, communities, or the larger society that help people deal more effectively with stressful events and eliminate risk. So what are the examples of protective factors? There is overall resilience. Resilience is the ability of a person to maintain a positive mindset despite being in a negative situation. Problem-solving skills, awareness and access to physical and mental health care, cultural or religious beliefs that discourage suicide, positive peer relationships, safe environment, interpersonal and community connectedness, positive adult relationships. So these are the examples of protective factors. So this is a comparison between risk factors and protective factors. It just goes to show here that our main goal is as much as possible to have more protective factors rather than more risk factors. Because if it is the other way around, it means that the patient has having higher risk, or the severity of the patient committing suicide is higher if there are more risk factors than the protective factors. While if there are still more protective factors than the risk factors, then there's still higher chance that the patient will be protected from committing suicide. So always remember, the history of suicide attempt is the best predictor of future suicide. Again, the history of suicide attempt is the best predictor of future suicide. It means that the more the patient is having previous suicidal attempt, then it is there is a higher possibility that the patient will commit suicide in the future. So what is safety? Safety stands for suicide assessment, five-step evaluation, and triage. It assists clinicians in conducting a suicide assessment using a five-step evaluation and triage plan to identify the following. So the following are the five steps of safety. First is identifying the risk factors. Second is identifying the protective factors. Third is conducting a suicide inquiry to determine the level of risk. Fourth is managing potential interventions. And fifth is documentation of a treatment plan. So just a brief background. Based on research, knowledge deficit and lack of education regarding suicide assessment have contributed to failure in identifying high-risk suicidal patients, which results in adverse sentinel events. Sentinel events, examples of this are death or any serious physical injury. So the safety tool is originally discovered by Douglas Jacobs, MD, and developed as a collaboration between Screening for Mental Health and Suicide Prevention Resource Center. As per this study conducted by APA, or American Psychiatric Association, the safety tool is recommended as a pragmatic, multi-dimensional assessment protocol incorporating the best known risk and protective factors. Nursing alert. Suicide assessment should be conducted at first contact with any subsequent suicidal behavior, increased ideation, or pertinent clinical change for patients prior to increasing privileges and at discharge. So again, suicide assessment should be conducted at first contact. Risk factors. The following are some examples of risk factors: suicide behavior, current past psychiatric disorders, key symptoms, family history, precipitants, stressors, interpersonal stressors, change in treatment, and access to firearms. Protective factors, there are two types, internal or external. Internal means the ability to cope with stress, such as religious beliefs, and tolerance to frustration. It is the patient's innate ability to cope with stress, or it's the patient's coping mechanisms. External is the responsibility. Example of this are responsibility to children or beloved pets, positive therapeutic relationships, social supports. External means you get this coping mechanism from other resources. May it be from a pet that makes you forget all your problems, or it can be other having relationship with your loved ones, your family support, the support of your community, your good relationships with your friends and family. So these are examples of external factors. Suicide inquiry includes ideation, plan, behaviors, intent, and exploring ambivalence. Ideation, there should be frequency, intensity, duration in the last 48 hours, past month, or and worst ever. Plan, the timing, location, lethality, availability, and preparatory acts. Behaviors, patient's past attempts, aborted attempts, rehearsals, non-suicidal self-injurious actions. Intent, extent to which the patient expects to carry out the plan and believes the plan or act to be lethal versus self-injurious. What are non-suicidal self-injurious actions? May I just ask? Non-suicidal self-injurious actions are actions that are not necessarily done by the patient committing suicide. However, due to a response to stress, the patient resorts to hurting himself. So these are non-suicidal self-injurious actions. Sometimes you will see some patients who are, when they are stressed, or when, for example, they have some demands that are not met, due to the stress of having the demands not met, they result in hurting himself by cutting themselves, or doing something, banging their head on the wall. So these are examples of non-suicidal self-injurious actions. Exploring ambivalence. This is the difference between reasons to die and the reasons to live. Risk level or intervention. The assessment of risk level is based on clinical judgment after completing steps 1 to 3. Reassessing the patient or environmental circumstances change. So the risk level and the intervention will depend on the risk level that is determined, or the risk factors, and as well as the protective factors that has been determined from step 1 and 2. So after all you have had your data, then that's the time that you will determine the risk level, and corresponding to whatever signs and symptoms that you have discovered to the patient, then that where your intervention will depend, which intervention you would implement for the patients. So as you can see here, there is high, moderate, and low risk. So high means there are more risk factors than the protecting factors. So because of that, admission is generally indicated unless a significant change reduces the risk. Also, suicide precautions will be implemented. Moderate, it means that the risk factors, the amount of risk factors and the amount of protective factors are equal to each other. So because of that, admission may be necessary depending on the risk factors, and a crisis plan may be developed, and giving emergency or crisis numbers just in case the client needs help. Low risk factor means that there are higher protective factors than the risk factors. So because of that, there are still a lot of modifiable risk factors that can support the patient and help the patient further preventing himself from committing suicide. So because of that, possible interventions may be outpatient referrals, symptoms reduction, and giving emergency crisis numbers if in case the client needs help. The last step in the safety tool is documentation. Risk level and rationale, treatment plan to address reduce current risk, medication, setting, psychotherapy, ECT, contact with significant others, consultation, instruction about firearms, and if relevant, follow up the plan. For youths, treatment plan should include roles of parent and guardian. So this is an example of a case scenario in which we will apply what we have learned about safety. So Paul is a 32-year-old single, college-educated male. He works as a graphic artist. He is smart and talented, gets jobs easily, but has trouble keeping them. He experiences intense shame about the quality of his work. Paul periodically engages in non-suicidal self-injurious behaviors by cutting himself on his upper arms with a knife whenever he feels stressed. He tried to end his life with intermittent active suicidal ideation with the plan to jump from the roof of his building. On 2 occasions, he has gone to the roof and contemplated jumping and was prevented by his cousin. Paul abuses alcohol and binges on cocaine. He has aggressive episodes, gets into verbal confrontations with strangers. Paul reports being physically abused by his older brother until he was 10. He lives with a roommate and supported by his uncle and cousin. He is likable when not in a stormy, aggressive mood. His relationships with his mother and best friend are his stated reasons for living. Paul had 3 years of outpatient therapy for depression and has been to the ED twice for NSSI behavior and active suicidal ideation. His ideation urges to self-harm fluctuate for the past 48 hours. So first is identifying the risk. So what are our risk factors based on a given case scenario? For Paul, nearing a deadline on an artistic project or shame about not being good enough and fear of exposure is a precipitating event that can trigger suicidal ideation. Depressed mood. Although it's not a risk factor for Paul's suicidal ideation, it does make him more vulnerable to being triggered. Patient is also having suicidal ideations with plan and previous attempt to commit suicide by jumping from the roof. Increased use of alcohol and cocaine are also warning signs for suicidal spikes. Protective factors. So these are Paul's positive traits, which can be considered as part of the protective factors. Paul is smart and talented, likable when not in a stormy or aggressive mood. Also, his relationships, these are external protective factors. His relationship with his mother and best friend are his stated reasons for living, and he has supportive family members in his life, his uncle and cousin. The first item where we focus on the patient's personal positive traits. These are examples of internal protective factors. Access to mental health service. This is also an example of external protective factors. Conducting suicide inquiry. So as per the clinical scenario given, Paul periodically engages in non-suicidal self-injurious behaviors by cutting himself without suicidal intent on his upper arms with a knife. He has tried to end his life and had intermittent active suicidal ideation with a plan to jump from the roof of his building. So the patient is having intent and the patient is having a plan of committing suicide. On 2 occasions, he has gone to the roof and contemplated jumping but prevented. So based on data we collected from steps 1, 2, and 3, we now determine the risk level and the interventions that we will do according to the risk level. What is the sad person score of Paul? What is his level of risk based on safety? Create a safety plan for Paul. So sad person score of Paul might be probably around between 7 to 10, which means based on the data given, client is highly suicidal. So hospitalization is really required for the patient in close observation. Level of risk based on safety, because the patient has higher identified risk factors, which outweighs the identified protective factors, then that means that the client is at higher severity risk. Creating a safety plan for Paul. So these are the safety plan that we can implement for Paul. First, it's determining warning signs, which is isolation, feelings of self-hate, and intense shame. For internal coping strategies, we have your video games, taking a bike ride. This is an example of what does he do for leisure or activities that make him happy and relax or divert his attention from negative thoughts, his hobbies and interests, people and social settings for distraction, such as roommates, school friends, online chat rooms, people contact for help. He has his uncle, cousin, and roommate, professional agencies to contact, giving numbers of professional for help, such as therapists, crisis hotline, cleansing the environment of dangerous objects such as knives. This is a part of making the environment safe. Limiting the amount of medication prescribed at any one time to prevent overdose, deleting phone number of drug dealer from his phone. So to prevent further communication with these people that would help, that would even encourage him to commit suicide. Having a plan in place to stay away from his rooftop when urges occur. So these are some of the safety plans we can do for the patient. Last step is document. Documenting the assessment of risk, rationale, interventions, and follow-up. And we should document it in the nursing cardex, suicide risk assessment forms, nursing procedure section. So as a summary, risk assessment means working out how likely it is that the hazard will harm someone and how serious the harm could be, which includes identification of risk and protective factors. The safety tool assists clinicians in conducting a suicide assessment using a 5-step evaluation and triage plan, identifying the risk factors, identifying protective factors, conducting a suicide inquiry to determine risk level, implementing potential interventions, and documentation of a treatment plan. So these are the reference. So that ends part 4 of our presentation. Thank you very much for listening. If there's any one of you who is having issues on accessing all these platforms regarding suicide that I have presented to you, please feel free to notify me. Also, if you have any questions, clarifications regarding the topics, please do not hesitate to reach out to me. Thank you very much and see you next time. God bless everyone.